So thank you for joining us today. My name is Joel White. I'd like to welcome you to our webinar that's going to focus on issues within the prescription drug space. It's called Price Controls, Understanding the Risks and Trade-Offs. My name is Joel White. I'm the president of the Council for Affordable Health Coverage, or CAHC, and welcome you here today. We've got a great panel with excellent speakers. We're recording the webinar, so it's available later. And I'm really excited to jump into the issue, but I want to set some background and context before we get going so that we have a level playing field of understanding. First and foremost, the Council for Affordable Health Coverage, or CAHC, you can find out more about us at cahc.net. We are a multi-stakeholder DC-based advocacy coalition that was started in 2001 to advocate for policies that lower the cost of healthcare for all Americans. And one of our big focuses and issues has been the cost of prescription drugs and making sure we have policies in place that make prescription drugs more affordable. And we've been working on that for a number of years, as has Congress and the Trump administration, the Biden administration. Goes back a long time. My background originally was congressional staff. Way back 900 years ago, I worked on the original Part D prescription drug benefit, Part B pricing changes, and other issues in the prescription drug space. And so now I'm doing this to make sure that we get better health coverage and more affordable health coverage for all Americans. And I think, a big issue here is that despite some spirited debate across both political parties and several administrations, we have yet to come to consensus on a set of policies that would drive affordability around prescription drugs. And so we're here today to explore some of the issues that are currently on the table and the trade-offs that are associated with maybe lower prices on the one hand, but less access on the other. And we're really excited to kind of get into that discussion. To that end, CAHC developed a list of about 20 different policy approaches Congress and the administration could take to make health coverage and prescription drugs specifically more affordable. They're in four primary buckets. Kind of the first would promote reforms that would enhance competition. Here, trying to get more products on the market, generics, biosimilars, brands, to get price competition so that costs would come down. Secondly, we've been very focused in leading a charge on value-based payment arrangements and making sure that if a drug doesn't work, that we don't get charged for it, but if it does deliver value, that we're paying appropriately. Third, we're very focused on benefit redesign. I'm sad to say that, back in 2003, when I was that congressional staffer in a room with Liz Fowler and others writing Part D, we didn't get everything right. And we didn't get everything right when the benefit was tweaked in the Affordable Care Act, and it's still not right. And so there's no out-of-pocket cost cap for seniors and the disabled in Part D. And that's something that's critically important because a lot of people end up falling off their medicines because they can't afford the out-of-pocket costs. So benefit redesign and making the Part D benefit more modern and more reflective of what people need, I think is critically important. And then lastly, and an important thing in this environment is that we stand as a shield against policies that would really undermine markets and do more damage to patient access. So we actually have filed a lawsuit on importation when the Trump administration put that out as a policy. We are opposed to things like international reference prices and kind of kicking that overseas to have other people determine how people get reimbursed and paid in this country. And we're opposed to, kind of heavy-handed approaches and in favor of freeing up markets. So there's a lot of discussion right now around prescription drugs and making it more affordable. It's an area that's really important because while it's only about 10% of what we spend on healthcare, it's perhaps the spending that most people experience at least on a monthly basis. So they see it a lot and they feel it a lot. They feel the out-of-pocket costs when they go to the pharmacy counter. And so it gets a lot of political attention, but also there's a lot of people who are struggling to meet those costs. So, reforms in this area are long overdue and needed. And so hopefully to that end, we can talk about some of the issues that are on the table today. The big one is HR 3. And this is the House Democrat leadership-led bill that would set up an international reference pricing model and tie it to prices paid in foreign countries where quality of life measures and access restrictions lead to lower prices. And so the trade-off there is lower price but less access, and we're going to get into those issues. Likewise, there's a host of issues that would reform FDA and CMS and other policies to enhance competition and address things like product hopping and pay for delay and issues like that. Transparency is certainly an issue that's on the table on both the drug side and PBM side, and trying to figure out what consumers pay out-of-pocket costs is a pretty important issue. And then I would say there's a fair amount of pain issues on the table, and by that I mean inflation-driven rebates and things of that nature that are really, I feel like the policies there are intended to generate a lot of revenue for approaches for the government. And then lastly, I think it's important to note rebate reform and the rebate rule, I think is on the table largely as a pay for. The Trump administration finalized a rule to change how rebates flow in the system and to change up that process. And I think that if Congress were to repeal that rebate rule, they'd find about $177 billion in the couch cushions that they might be able to use for other issues, but we'd lose some benefits that might flow from the rebate rule as well. So all those issues are kind of on the table. We're going to get into all those issues today. We've got an awesome panel. I'm going to introduce them kind of one by one, but to kind of kick us off, first and foremost is Michael Shimataro, sorry. We talked about that in advance, and he's got the hardest name of all the panelists, so I won't butcher anyone else's name, I hope. He is the Vice President of Research at the National Pharmaceutical Council, which is a member of CAHC. In that position, he plays a pretty key role in developing the policies and unearthing problems and highlighting solutions that the National Pharmaceutical Council members hope to advance. And so he's been in the industry for a long time and is a nationally recognized expert. And with that, I would turn it over to Michael to open things up.
Thanks, Joel. Next slide, please. So today there are 4 points I want to make regarding the trade-offs and risk associated with price regulation. Next slide. The 4 points I want to make is, the first point is that innovation does matter to patients. Second point I want to make is policies focused on reducing drug prices present trade-offs for patients. Third point to make is, there's a significant amount of uncertainty regarding the potential impact of these policies, and therefore it's incumbent on policymakers to look at the full range of outcomes. Fourth point I want to discuss is there are alternative approaches to HR 3 that can both address the goals of reducing costs and maintaining incentives. So now let's turn to my first point, next slide, in terms of why innovation matters to patients. There's been numerous studies on the subject, but I want to highlight a study last year published in Health Affairs by David Cutler and Jason Buxbaum out of Harvard. This study looked at the sources or the drivers of improved life expectancy between 1990 and 2015. And during that time, for reference, life expectancy increased about 3.3 years. What they found is that approximately 44% of that increase was due to public health initiatives. And a close second, what they found is approximately 35% of increases were due to biopharmaceuticals. The study is important because it reinforces what other studies have shown, and that is biopharmaceuticals are a key driver of improved patient health, and therefore it's important to maintain appropriate incentives. So next, I want to talk about my second point. What is the relationship between incentives and innovation? And really, when you review the literature, there are 2 points that emerge. The first point is that increase incentives, there's a clear relationship, between innovation and incentives. When incentives increase in a positive manner, you see a corresponding increase in innovation as measured by the number of new drugs. Conversely, when incentives decline via price regulation or some other mechanism, what you see is a decline in innovation. And this finding is really consistent with what the CBO said in its recent pharmaceutical R&D report. The second point that emerges from the literature, which has gotten less notice, is that in terms of how price or impacts of price regulation or incentive changes flow through the system, they're not uniform. Specifically, you'll see differences emerge across 2 areas. 1, disease areas, and 2, firm types. And there are a couple things that play here. The first thing is the technical risks of developing a drug is really different by disease area. And second, what you see is that the risk tolerance varies quite a bit by firm. I mean, think about small biotech and venture capital versus large biopharma, very different drivers and motives. So while these relationships are quite clear and the direction is well established in the literature, what is not as clear is what is the magnitude of these relationships. Next slide. And there are really 3 pivotal studies on this that get referenced in this space. I'm not going to dive into the technical details of the studies, but what I want to do for you is I want to highlight 3 key observations. The first one across these 3 studies is that there is no clear consensus on the impact of price regulation on innovation. What you actually see is quite a large range. And the interesting thing is the CBO estimate, their analysis of HR3 is actually on the lower end of that range. The second observation I want to make is as you look across these studies, you'll notice that the markets that they look at are different. 2 of the studies focus on the US market, while the third one focuses on the US plus ex-US markets. Now, we all know the significance of the US market in driving innovation. So this raises an important question when you're thinking about the studies. How do you compare studies that focus on US plus ex-US versus studies that focus solely on the US? And you can see that the interpretation is important here because this one study that did look at ex-US shows a much lower relationship between innovation and incentives. The third point, look at the periods of when these studies were conducted. The most recent period is over a decade ago. If you take a step back and you think about what's happened in the biopharmaceutical space over the last 10 years, there's been quite a few changes. 2 things are really important to point out. 1, you've seen an increased role of small biotech and venture capital over the last 10 years. It gets more and more important each year. The second thing is you've seen a shift from small molecules over to biologics, orphan disease, next generation therapeutics, such as cell and gene therapy. And these changes, they really are quite significant. And they matter because they really fundamentally change the risk composition of the industry. And so this ties back to these studies and raises a critical question. How representative are these studies of today's market? So when I look at these 3 observations and I step back, I see 2 things that are kind of my takeaways. One is that A, there is a significant amount of uncertainty in terms of what the potential impact may be. And B, that risk or that uncertainty, if you look at the risk is that the impact will actually be much higher than what the CBO estimates in their analysis of HR3. Now, this isn't meant to instill fear or the like. The simple point I want to make here for policymakers is we shouldn't be focusing on point estimates. We need to consider the full range of possibilities. That's just responsible risk management. All right, so we talked about the potential for impact. I've explained at a high level why there's uncertainty. Let's apply this at a real world example next. So when thinking about potential impacts, it's important to understand this point. The biopharmaceutical industry is not a static entity. Rather, it's very much a dynamic ecosystem that responds to incentives, be those incentives negative or be they positive. So with that in mind, let's take an illustrative example of HR3, and I'm referring to the most recent version. So looking at that, let's look at how an economically rational firm would respond to some of these elements of this policy. By economically rational, I'm talking about a firm that maximizes its returns. So on the positive side, what do you see? Well, there's a cap, a $2,000 cap on Part D out-of-pocket costs for patients. This is a good thing for patients as it lowers their financial burden, but it also reduces market access risk for biopharmaceuticals. This is a positive incentive, and you would expect to see a corresponding increase in innovation targeted towards Part D. Now, the flip side, there's three elements here that I want to highlight that are really adverse incentives for innovation. The first one is HR 3 focuses on a subset of drugs, focuses on those with the largest net spending and the new drugs that have a price tag above the US median income. The second thing it does is it, for those drugs that go through the negotiation process, it caps it at 120% of the average from 6 key ex-US markets. Third thing that's highly important is you look at the Part D reforms that add significant discounts on top of the negotiated prices. So what does this mean for the US market? There are also consequences ex-US, but let's focus on US today. Well, first, overall innovation will drop. That's not surprising based on what we discussed. But the more important point in my mind is the next two observations. These incentives from an economically rational firm incentivize companies to focus on smaller population therapies as a way to potentially maximize returns and avoid the negotiation process. The second thing this does is it incentivizes firms to move away from Part D patients and focus more on commercial patients, given the lower expected returns under Part D. This is meant to highlight the perils of regulating prices. It's not just simply a matter of, okay, we're going to have less innovation, but there's also a potential of how you will skew incentives. So the question is raised, this raises the question, is there a better approach? And I think the answer is yes. Next slide. Let's talk about that. So when people talk about price regulation, drug price regulation, there are really three separate policy objectives that are overlapping in place. One is there's a goal, obviously, to reduce total cost. The second objective really is focused on improving the value of each dollar spent. And the third objective is reducing patient out-of-pocket. Now, each of these, there are a variety of policies you can use to address each of these particular objectives. But the way to go forward is really to do this in a holistic and evidence-based manner. Okay, so what do I mean by holistic? I'm talking about reforming the entire innovation ecosystem rather than focusing on pieces. But the entire ecosystem, what am I referring to? I'm referring to, okay, initial drug development, or think about how we can reform basic science investments. Think about patent reform. Once a drug's on the market, it's time to think about benefit redesign, rebate reform, the appropriate use of value assessment to inform coverage decisions, and the use of value-based contracts in appropriate situations. And then when a product loses its branded, the branded period ends, I'm focusing here on biosimilar reform. Now, policies focused on each of these areas, they could have really a negative impact or a positive impact on the ecosystem. The devil's always in the details. But the point I'm trying to make here more broadly is that if it's done in a thoughtful and evidence-based manner, there is the opportunity to really address the costs while maintaining incentives for innovation, which I think is what everybody wants at the end of the day. Next slide. So to quickly sum up my main points, biopharmaceutical innovation matters to patient health as it's been a key driver of patient health. Policies focused on reducing drug prices will lead to fewer drugs, which presents trade-offs for patient health. 3, there are significant uncertainties on what the magnitude of impact will be of price reform, and therefore it really is incumbent on policymakers to consider the full range of possible consequences when thinking about legislation and regulation. Finally, there are alternative ways forward besides HR 3 that can both address concerns around costs and maintain incentives. Thank you. I'm now going to turn it back over to Joel.
Thanks, Michael. Really appreciate your perspective and doing a bit of a deeper dive into HR 3, and which I think is a fairly radical approach. But next, want to turn it over to Craig Garthwaite. We got two Craigs today. Dr. Garthwaite is a professor of strategy and director of healthcare at the Kellogg School of Management at Northwestern University, where he is an applied economist, and his research really examines the business of healthcare with a focus on the interaction between private firms and public policies. And he's done some recent work on payer and provider sectors and really focused on the impact of the Affordable Care Act and Medicaid, managed care, and some of the trade-offs that exist between investments in new product development and the evolving world of precision medicine, patent protection, and pricing on pharmaceuticals. So Dr. Garthwaite, really appreciate you being here today. Looking forward to hearing what you have to say.
Thank you. And thank you everyone for joining the webinar. So I'm going to pick up a bit on what Michael was saying, and maybe try and take a step back before we talk about HR3 and just get a sense about sort of what is it we're trying to think about maximizing when it comes to our policies related to drug development. Everything about drug development is often referred to as an access and innovation trade-off, where we trade off some reduced access today in order to get products in the future. And so in reality, what we're really talking about is we're really just talking about access, but we're talking about access in different time periods. How do we think about trading off access to drugs today that might be reduced by high prices in order to provide the incentive to get new products, which then provide access to people in the future? Noting that today, sort of the largest form of access reduction is that there are not treatments that exist for your medical condition. And for those individuals, there's no amount of money you can have, and there's no amount of money you can use to buy your way out of a negative health shock. So then when we get to think about why we have this access innovation trade-off, it's related to the fundamental nature of drug development. Making a new drug requires a large, fixed, and sunk investment today to develop what is effectively a public good. You are developing new knowledge. That knowledge can be used by anyone in the market. Right? Absent government protection, it's very hard to make any profits on developing a public good or developing new knowledge. So we provide this time-limited period of market exclusivity for firms that are developing new products overall, but new drugs in particular for our conversation today. And so everything about this then means that the government's going to be involved. We often hear people talk about we need a free market for prescription drugs. I would say that's not really true. From the beginning, the government's involved by establishing intellectual property standards that govern this trade-off between access and innovation. And so what we're really striving for as policymakers and society is how to maximize value out of this trade-off. And as long as the products that we develop in the future, because of the innovation incentives we provide, generate more value than the reduced consumption of drugs today, where society is going to be better off. Economists refer to it as it's a welfare enhancing policy. So the role of government is how to manage this trade-off. And I think there's two primary things I want to talk about here. And I'm happy to take questions on any topic related to this. But it's really, how do we think about limiting the pain from the reduced access today? And how do we think about making sure that the period that we give the companies is sufficiently long to provide incentives for innovation, but not so long that it provides extra economic rents or extra economic benefits to firms? On the reducing the pain side, the one thing we note about health insurance is that unlike other markets, health insurance can blunt some of the effects of high prices on those who are sick. By having a well-functioning insurance market, individuals can still get access to even high-priced insurance. But that really, what's doing a lot of heavy lifting in that statement is a well-functioning and well-designed insurance market. And as Michael pointed out, and Joel talked about to begin with, there are some real insurance design questions we have with Medicare Part D. I would argue that Medicare Part D is a particularly poorly designed insurance program if you have very high-priced pharmaceuticals. That's perhaps not surprising. Joel said he felt bad having designed it, but the market, as Michael said, has changed a lot since when we wrote Medicare Part D. And we do have the ability to generate products that create a ton more value for patients. They're often quite tailored, and so the value is very specific to individuals in terms of a precision medicine dynamic, and therefore the resulting prices are very high. And therefore, if you're exposed to sort of unending cost sharing on that drug, we're basically unwinding the generosity of insurance. And so as I started to think about things that policymakers could do to better manage the access innovation trade-off, one thing to focus on is excessive cost sharing for patients. That's well beyond anything that's meant to be a negotiation tool or anything that's designed to eliminate the excess consumption of drugs because the prices are made artificially low by insurance. And so really redesigning Medicare Part D should be at the front of any effort that government is thinking about when it comes to the access innovation trade-off and development incentives for pharmaceuticals. The other thing I think that we should focus on is making sure that the period of market exclusivity is explicitly time limited. And now after that, we have policies in place to support a robust generic and biosimilar market. And there are a variety of things we can do to try and address that. I testified in the House Oversight Committee last week. I outlined a number of them. But just for the purpose of this webinar, there's two I would focus on. One is on making sure that we have a system set up for what I refer to as a small market generic or biosimilar. This is a drug that does not have a lot of patients and therefore might struggle to support multiple competitors in the generic space. For those markets, we might need to look for other government solutions in the term of maybe tenders or auctions or explicit price regulation or something that addresses what happens in a small market when exclusivity runs out. The second is I think we need to think more carefully about the contracting structure for rebates related to biologics and biosimilars. And really think carefully about whether we want to have additional antitrust scrutiny on contracts in this space that are going to reference the rival product. And what I mean by that is sort of a contract that says, well, I, as the biologic, want to make sure no competitors on my tier of the formulary. Those might be viewed as anti-competitive, and I would encourage our antitrust authorities and policymakers to think more carefully about that. And so to summarize, there's some types of policies we can think about, but fundamentally what we want to start thinking about is the idea that government has a role here to promote competition when products have market exclusivity and to promote competition between branded substitutes and to make sure that market exclusivity is going to be fundamentally time limited. So I'm going to turn it back over to Joel now, but I'm happy to take any questions after the opening statements.
Great. Thank you, Craig. Really appreciate it. And we'll go to the Craig 2.0. Dr. Craig Mitten, I'm really excited. It joins us from Canada, and is Dr. Mitten is Professor of Health Services and Policy at the School of Population and Public Health at the University of British Columbia, and he's been there for a while. He is a senior scientist also at the Center for Clinical Epidemiology and Evaluation there, and he's really focused on applied health economics research and really with a goal of impacting policy and clinical practice. And so, Dr. Mitten, looking forward to hearing your comments.
Great, thanks very much, Joel, and greetings from the west coast of Canada. I just offer three questions to start. What if you could reduce healthcare costs and improve value for money? And then what would you say if there was a framework and tools available to work on this today? And then what about if you knew that many other countries have gone down precisely this route? Next slide, please. As we know, the US spends more on healthcare than all the other OECD countries, yet doesn't have better outcomes. Now, this isn't the Canadian trying to be overly critical of the US system. It's just an observation, one that you all know. And the US has focused on achieving greater value largely through market adjustments where individual choices are paramount. But at the core of understanding the issue of how much to spend on healthcare is the issue of making choices. We've heard both Joel and Mike already mention this idea of trade-offs, choice making, looking at what interventions to fund and what not to fund, or how much of something to fund and how much of something to pull back on or to fund less of. And frankly, this is widely accepted, this idea of trade-offs and choice making. this is widely accepted across high-income countries, not only in my own country, but if you look across Europe, it really is standard practice to be thinking in terms of trade-offs and choice making. Next slide, please. Just a very quick snippet on where I'm coming from. As you may or may not know, Canada has universal coverage, but what I'm referring to there is a public basket of goods, publicly funded basket of goods for all citizens. But there's some anomalies. It's not a perfect system. Drugs, and the topic of today's conversation, is one of those anomalies. Oral care is another one of those anomalies. On average, we spend slightly higher than what other OECD countries spend as a percent GDP. And you know what, frankly, we have mixed results in terms of wait times. In some cases, wait times are not good. In other cases, they're okay. But generally, we have very high patient satisfaction. I like to think of it as we have good coverage for all, as opposed to exceptional coverage for some. But there's room for improvement within the Canadian system. And I think even within a universal coverage system, we still see some disparities relative to socioeconomic status. So those of lower SES do not access drugs, do not access healthcare to the same level of those at higher income levels. Next slide, please. What we've done in Canada, what we've done in many of these other countries where trade-offs and choices are paramount, is we've really picked up on these 2 points. The first being what the Council for Affordable Healthcare has as, when you go to their homepage on their website, it's the thing that sticks out at you. A singular focus on bringing down the cost of healthcare for all Americans. And we've really tried to work on that with respect to thinking about this concept of value. And Porter, as many of you have seen, is widely cited from the New England Journal of a decade ago, stating that value is defined as health outcomes achieved per dollar spent. And this idea of trade-offs, this idea of choice making, really comes down to these 2 very clear objectives: bringing costs down and improving value. And if you recall back to Michael's slide on alternative policy approaches, both of these points were directly in one of the slides where he was referring to what are some of the options to look at. And then 2 little nuances I would add to that. Benefit, when we're thinking about benefit for drugs, should be a construct of all the relevant objectives, even if they're hard to measure. And we can think about, questions of equity, access, prevalence, severity, effectiveness, a whole basket of criteria that form what we want to be thinking about in this construct of benefit when we go to assess value. And then further, once benefit is assessed, it can then be explicitly compared to the cost of a given treatment. And I'm not going to go down the route that the other Craig was speaking around in terms of trade-offs of innovation. I'm just thinking purely in terms of assessing the costs and benefits of a given drug at hand. Next slide, please. So what might this look like? What we've come to, certainly in our own system in British Columbia, and as I say, in many other countries, it's this idea of relying on a values-based framework for decision-making that moves away from simplistic cost per quality adjusted life year assessments and moves away from one-off health technology assessment decisions and incorporates pharmacoeconomics, incorporates health technology assessment into a broader values-based framework. When I say moving away from cost per qualities and the incremental cost effectiveness ratio, what I'm really getting at is this idea of applying a multi-criteria approach to decision-making. If you Google MCDA, multi-criteria decision analysis, you'll get hundreds of thousands of hits. This isn't something that us Canadians developed. It's been around for decades. Setting the multi-criteria approach within a values framework ensures that we get at a full range of benefit for the drug decision-making process while moving towards achieving greater gains in terms of value overall. Ideally, certainly in our system where we have a predominantly publicly funded system, but many aspects of the US system, I would argue, would also hold for this. Ideally, looking at what are the public values behind the criteria to inform decisions of value assessment. And it's tried and true methods to abstract those public values and develop criteria and apply value assessment within a formal structured process. Next slide, please. This is what I'm driving at, what I'm getting at for a starting point for needing to make choices about what to fund and what not to fund. PSRA, priority setting and resource allocation, as envisioned here, is based on a values framework, and it provides the how for making these trade-off decisions. Public engagement can be built in, as you see, at the various stages of the process. Health technology assessment is an important input, but the process isn't HTA in and of itself. HTA is a feeder into the choice-making process. And on the left side of this figure is the idea of areas for growth, investment, and areas for reduction or disinvestment. So the idea is to look at, through a values-based process, identifying a set of criteria, I mentioned some earlier, that can help in explicitly assessing the value for the given drug, technology, service, treatment, intervention, forming within that multi-criteria decision process with input from pharmacoeconomics or health technology assessment, robust evidence base to come up with options for investment and disinvestment. And this idea of reallocation, moving from areas of low value to higher value, gets at that concept that the Council for Affordable Healthcare has on their website of bending the cost curve, of reducing costs. You'll necessarily start to see costs under control while also looking at that concept of value for money. It's also greater transparency. You can improve clinical engagement in this type of decision making. And I guess I just want to leave you with the thought that this isn't just, me saying, oh, here's my pet framework, have a go. I've personally been involved in literally dozens and dozens of applications of this framework. In fact, probably close to 100 that I've been involved in personally. There's been hundreds and hundreds of applications of this exact framework across many countries with high levels of success, assessing value, bending the cost curve, improving transparency, gaining clinical engagement. Now, as one of my colleagues, Francois Dion, likes to say, the applicability of this type of framework, this type of values-based approach to the US is not indiscriminate. What we mean by that is that we need to look carefully at the feasibility and likelihood of success in any given setting, certainly with the myriad of how the market is based in the US within healthcare and the many different segments and sectors within healthcare in the US. I'm not suggesting a wholehearted application of this or a blanket application of this, but I would suggest that there's many areas where this type of values-based approach to looking at trade-offs could be introduced to assist the US in achieving better value and bending that cost curve. Next slide. So I'll just wrap up here by saying that measuring value is of utmost importance to decision makers in every high-income country, frankly, outside of the US. The concept of trade-offs is not only understood, but is applied. And it gets at the concept of shifting or reallocating resources, and as such does bend that cost curve. Many countries are leaning towards a broader definition of value based on multiple criteria. So moving beyond the incremental cost effectiveness ratio and thinking of health technology assessment as an input into a broader values-based approach to value assessment. Certainly there's lots of traction with deliberative frameworks for priority setting in many different settings, and it does allow for assessment of opportunity cost in a fair and transparent manner. So I'll leave it there and look forward to some discussion. Thanks very much.
Thank you, Craig. Appreciate your insights. Next up is Sue Peshin. She is the president and CEO of the Alliance for Aging Research. It is the leading national nonprofit organization dedicated to accelerating the pace of scientific discoveries and their applications to improve the experience of aging and health. Since 2012, she has led the Alliance's efforts to increase NIH funding for Alzheimer's disease and aging research funding. She is actually on the board, the advisory board of the National, the National Advisory Council for the National Institute on Aging at the NIH, a critical role as they develop their budget and agenda. And I'm kind of a dork, so I really like they've got this thing called NERDY, which is Nurturing Engagement in Research and Development with You, which is funded by PCORI, and it's all about basically getting family caregiver coordination for seniors. So Sue, really appreciate you joining us today and look forward to your comments.
Thank you, Joel. And thanks to CAHC for inviting me to participate with all of you. It's really been an interesting discussion so far. So from our perspective, Congress is laser focused on drug pricing, as we all know. But I want to back up and acknowledge that older adults face substantial out-of-pocket healthcare costs each year for a variety of costs in their premiums, deductibles, cost sharing, physician visits, hospital stays, and the services that still aren't covered, as we know, vision, dental, and hearing. And these costs can really be insurmountable, especially for the 1 and 2 Medicare beneficiaries that live on annual per capita income of less than $26,200 a year. And I think it's also really important to put prescription drug prices versus payer spending into context. And what do I mean by that? Well, if you look at CMS's own data, they report that prescription drug prices went down in 2019, but Medicare spending for prescription drugs went up. And the increase in the spending side is not related to pricing, but to the growth in the number of Medicare beneficiaries, which means more people needing prescriptions. The aging of the baby boomer population into Medicare is going to continue. And it's going to increase the number of beneficiaries for the next several years. And that's the main reason for higher utilization and subsequent higher spending in this area. So I know we're talking about trade-offs in drug pricing proposals, and I'll go there now, but I just wanted to address the hype and our desire for Congress to ultimately tackle total costs of care. And our feeling about the fact that drugs are inaccessible and inaffordable to many older adults goes back to what Craig Garthwaite mentioned, which is private Part D insurers implementing aggressive cost sharing. And the Kaiser Family Foundation reports that about 1 million Medicare beneficiaries are classified as having those high out-of-pocket costs, which equates to an average of more than $3,200 in expenses in each year, which is a lot, especially if you think about that fixed income amount. So the emphasis on saving beneficiary money at the point of sale is really a critical point for us. And the main proposal that would be most significant for beneficiaries in the Medicare Part D program is an out-of-pocket cap. And I know there's support across the board for this, but I feel like the potential impact of this monumental proposal really gets lost in debates over other aspects of how to tackle drug pricing. And all the proposals under current consideration include an annual out-of-pocket cap, but we think patients would derive greater benefit from a consistent monthly cap in Part D out-of-pocket expenses. And a recent PAN Foundation morning consult survey that just came out a couple of weeks ago reported that most beneficiaries can only afford up to $200 a month on their prescriptions before needing to either modify or forego medications or adjust other areas of spending like rent and groceries. Any proposal that adopts an annual cap in Medicare Part D needs to be paired with a smoothing mechanism, because if you're hit with something mid-year and you have high costs all of a sudden, you need something to allow the spreading of costs over the benefit year. And the combination of both capping and smoothing will help promote both health and access so that folks can stay and afford their medically necessary medications. Now, so these proposals cost money, so how do you pay for them? And one thing I think that we haven't been talking about much is, because keeping insurance premiums at the same level year after year is considered sacrosanct. And we think the option to raise premiums should be on the table if it means beneficiaries can get relief in a meaningful way in their out-of-pocket costs. And a majority of beneficiaries agree. We did a survey back in 2019 with Morning Consult that found that more than half of older adults were willing to pay more in monthly premiums to allow a cap on their out-of-pocket costs. And we also agree wholeheartedly with supporting Part D restructuring and also with inflationary penalty proposals, because both of those would generate cost savings and are good sort of regulatory solutions. But unfortunately, the House Democrat leadership, as well as the previous White House, were spellbound by international reference pricing. And my organization, Alliance for Aging Research, strongly opposes any international reference pricing proposals, whether it's HR3's version, International Pricing Index, Most Favored Nation, in any type of drug pricing reform legislation. And our reason is a little bit different than some of the things that have already been spoken to. All international reference pricing proposals share a common flaw. They would import to the US the use of discriminatory cost-effective standards that other governments use. Many of the reference countries like the UK, Canada, and Australia make drug reimbursement and coverage decisions based on cost-effectiveness assessments tied to the quality adjusted life year, or known as the QALY for short. QALY assessments assign a value to the patient population a treatment's intended for, and they're based on the perceived value of living with a given condition for a certain period of time in comparison to being in perfect health. So the actual impact of QALY-based cost effectiveness is quite large, because if a treatment is for a group that's sicker, older, or includes people with disabilities, or is focused on a population that has historically faced inequities in society and in the healthcare system, like many racial and ethnic groups in the US, the treatments oftentimes are assessed as being less valuable. Or another way of saying it is that those groups are considered more expensive to treat. And when you conclude that a treatment isn't cost effective, insurance companies can justify restricting access by not covering it or using management techniques like step therapy that restrict access to it. And healthcare rationing is common in other countries. You heard, Craig speak about it pretty openly, and that's what we would start doing here if we adopted this. Now, we have a very different healthcare system in Canada and many other countries. What I find really interesting is countries like Canada, to Craig's point, as well as the UK, are sort of coming to a reckoning because they've been using QALY-based CEA for a number of years. And I think having gone through COVID, are sort of having ethical, oh, what have we been doing all this time? And maybe gradually moving away from that, where the US we're gung-ho. And here we have something called the National Council on Disability, which is an independent federal agency. And they've been all over this, cautioning against relying on the QALY because it would undermine the Affordable Care Act and major US disability and civil rights laws like the Rehab Act and the Americans with Disabilities Act. So again, it goes against existing law. It hasn't been challenged in that way. But in April of this year, the council sent a letter to the Congressional Budget Office because the CBO recognized, yeah, we're using QALYs, it's what we've got. And they expressed their concern with that. They stated in the report, this makes light of the fact that the QALY assigns a lower value to the lives of people with disabilities and chronic illnesses. And it also ignores the fact that countries that rely on the QALY to set drug prices have restricted or denied patients with disabilities access to effective drugs used to treat chronic conditions and to breakthrough medications. And in 2020, the DNC platform stated outright that Democrats are going to ensure that people with disabilities are never denied coverage based on the use of quality adjusted life year indices, and we want to hold them to that. So we believe policies that rely on quality-driven international pricing metrics need to be prohibited, not embraced. And the other aspect is the way that we've looked at it is that it's going to have an outsized negative impact on innovation in areas of high unmet need like Alzheimer's disease. Because if you consider the risk of investing in medical breakthroughs for these types of conditions, rare diseases, Alzheimer's, companies need to have successful products to underwrite and subsidize investment into these new areas of research. And we did an analysis with Vital Transformation that showed that implementing international reference pricing in the US would decimate the clinical development of therapies for Alzheimer's disease and related dementias, which already have an extremely high failure rate, and drastically reduce the revenue that helps support the research. So we feel like there's, more than 47 million beneficiaries that are enrolled in Medicare Part D. The inability for, a number of them to pay for out-of-pocket costs can oftentimes mean the difference between health and sickness, life and death. We've already had way too many deaths over the last year. So we want Congress to be focusing on reducing their out-of-pocket cost burden, not on cutting treatment access with international reference pricing. And I look forward to questions. So thank you.
Thanks very much, Sue. An important perspective and the trade-offs involved in dealing with HR3. And so I wanted to get to I've had some conversations with Democrat leadership, staff, and committee staff and the authors of HR3, and basically they argue kind of two things. The first is that they want these lower prices, and they don't really argue that there's going to be a negative or trade-off associated with that. And they basically say, well, the CBO said we're going to lose maybe 8 to 30 new products as a result of the incentives tied into HR3, and they say we don't believe that pharma won't keep innovating. And the second thing they argue is that maybe this is a 3 to 5% hit on the manufacturer bottom line, but they can just kind of redirect money from their marketing budget or from their profit margin and just kind of make up the difference here. How would you maybe Michael or Craig Garthwaite, either one, kind of kick us off on discussing those two arguments and whether they hold water in your opinion?
I'll go first, Joel. I appreciate the question. I think the CBO estimate is really an underestimation of the potential impacts. The one thing the literature is quite clear on is that there is a strong relationship. I think, there's obviously, we can disagree on the extent of potential impact, but there will definitely be impact. And as I highlighted, if you look back in terms of life expectancy and the like, you see that drugs are a key driver of improved health. So, at the end of the day, I think there are better ways to deal with this than just simply cutting prices. I think you need to kind of look at the whole ecosystem and what you can do to improve the overall ecosystem.
Yeah, I would agree with Michael. I think listen, I can understand why it's tempting of policymakers to assume there won't be an effect, to think that pharmaceutical companies are rich and therefore it's not going to be a problem to take away some of their money. They'll just redirect from other parts. Frankly, that's just not the way that companies work. Certainly not publicly traded companies. So they're not going to reduce their profits. They're not going to shift things from marketing. And frankly, marketing and innovation are complements. They're not substitutes. You do marketing to increase the size of your market, which therefore can support greater investments in R&D. So at best, that's a naive way of looking at it. I would also note that, and this sort of relates to some of Craig Mitten's points, the United States doesn't get the luxury that other countries have. And Craig should have said in his talk, I think it's very fair, that for the decisions that Canada is making, we're going to put aside questions of innovation. And frankly, Canada can do that. Canada is at best, it's a small or mid-sized US state. And so they can choose not to worry about innovation. The US doesn't get that opportunity. If you think about the relative size of the US to world profits, and really to the attention of biopharmaceutical companies who often focus, to be honest, on the US, Germany, and Japan, really, when they start thinking about where or what markets they're going to target to make the investment decision. And that's the important part. How do you decide to invest in something, not where will you ultimately sell it? That's what they focus on. And that's what the United States has to be cognizant of. We will see these drugs available in lots of European markets after they've made the decision to develop it, because the marginal cost of producing the drug is low. And so once you've made the drug, you're willing to sell it lots of places. Even saying that, the UK and other countries are facing trouble on getting people to be willing to sell them the drug, even when the marginal cost is low. Perhaps most famously, the fight with Vertex about Orkambi and Kalydeco and the unwillingness to cave to demands there. So the United States really has to think about more than just the clinical value of the drug. They have to think about innovation, and they have to think about the benefits that society in the US and the world overall get from the very existence of these products.
Yeah, Craig Mitten, I'm wondering, I looked at some of the numbers before the webinar here, and in Canada, about 58% of products available compared to what's available in the US, about 14 months or more wait time based on the product until new innovative product is available in Canada. But you say in your slides, people are generally happy, kind of happy. Talk about that trade-off. Like what's going on there?
Yeah, no, it's great. Thanks, Joel. You raise a good point, and I appreciate both Craig and Susan's perspectives. And certainly Canada is nowhere near the size of the US on that. I would offer 2 points on the innovation perspective. One, not all innovation is good innovation. And so we have to be much more discerning about what we're paying for. And when I talk about a values-based framework, and absolutely, Craig's right. I did focus on the value of the drug itself in terms of the clinical benefit and the benefit well beyond, Susan, what a quality would bring to the table. You and me are on the same page on that, absolutely. But you could also do value assessment around the return on investment from an innovation perspective. And I think that much more scrutiny is justified. Instead of blanketing all innovation being good, acceptable, we're willing to pay whatever we should for it, to say, well, what are we actually getting for that? If the US is leading and other countries benefit from that, fair enough. But is the level that the US is paying acceptable? And I would say probably not. And so where can we get to a point in the US where the trade-offs are acceptable, even noting some additional pay for innovation?
I have one more question for Sue, and then we got a couple of questions from the audience. Sue, the benefit redesign that you talked about, that's so important, the smoothing, the upfront help, and then the back end catastrophic, that's got bipartisan support, right? And it's supported across industries, like the payers. We've got payers on our board, PBMs, drug manufacturers, patient groups, your consumer organizations. Everyone's saying yes, right? So why don't we just do that?
Yeah. Sounds good. I think there's the draw of the pay for, and and also to your point about just what CBO came out with in their analysis, and I agree with all the other panelists. CBO is wrong, and they've been wrong before, and the way that they're examining the industry is not really how the industry works. And what I am most worried about, as I said in my remarks, is just the impact on areas of high unmet need. That's really where the biggest hit is going to come from in terms of new medications, is those places. To Craig's point, you want value. So what do you want to do? You want to address diseases where we have nothing, right? And that's exactly where this is going to hit the most. So, it's not a good path to go down. And sure, Joel, let's just do that. But we have to get to that place, and folks just have to get to a place of recognizing we got to let go of international reference pricing for once and for all.
So let's maybe stay on this. The one of the questions from the audience, from my good friend John Green. Any thoughts about the German model? Is this something that could be adopted with respect to access and development? I know the Biden administration seems to be very keen on what's happening in Germany. Any thoughts from the panel?
So the German model, and there's a lot of nuance to it, but broadly speaking, it's, a drug, so everyone's on the same page. It's a drug gets released, so the price chosen by the manufacturer. You have a year to generate new evidence. Then you can use that evidence to engage in effectively a bargaining process where you're bargaining with roughly the entire insurance sector at once. So you're introducing kind of monopsony or sort of single payer type bargaining, even in a multi-payer setting. There's a lot, I butchered a lot of nuance around that, but broadly speaking, I think when you're talking about the German model, that's what you're thinking about. And it's really cost effective against an existing alternative. So I think there's a lot to learn from Germany. I think one interesting thing that worries me a bit about it, though, is how we think about cost effectiveness against a generic portfolio as opposed to a branded portfolio. And so if you think about like cardiovascular drugs, by this point, our existing alternatives are primarily generic, not all, but like we have a huge, very well-functioning generic portfolio there. And so to beat that in a cost-effective or a comparative effectiveness standpoint between, what you get per benefit for a generic drug is a really high bar for new brands. And I worry that sort of that would just shift innovation in a really weird way based on the vintage of the existing product as opposed to the pure value. So you got to think about how you measure value there versus the existing alternatives. Overall, I'm sympathetic to both the German model and to Craig Bitten's point about the fact that we want to think about the type of innovation we're getting, and we do. And I've written a lot about the need to think about the type of innovation that we want to think about. I would say though that when it gets outside of measuring the clinical value of the drug, we're just not very good at figuring out how much people are willing to pay for certain types of innovation. It's the reason why markets exist, to allocate those resources. And I think there's a certain degree of hubris to think that in this sector, which might be one of the most complicated, that a series of technocrats are going to be able to figure out how do we think about identifying willingness to pay that exists beyond clinical value. So things like insurance value and scientific option value and all of those things. I'm an economist. I have a lot of respect for sort of thinking about modeling these things, but I think it's actually a lot harder than people think to measure those alternative sources of value as opposed to the pure clinical value, or other things related to the performance of the drug as opposed to the options it creates for future treatments.
So I'd like to chime in here too. I'd like to add on. I agree. The other thing to keep in mind is that Germany is a relatively small country to the US. In terms of measuring value, Craig mentioned some of the limitations, but part of it comes down to priorities. And the question becomes, where should priorities be measured? Should it be at the national level, the state level, or more at a local level? And implementing a complicated system like Germany, the level of complexity here in the US, I think, would be difficult. The other point I'd like to make is, in thinking about driving a value system, there are really two elements, right? There's measuring value and paying for value, but I think there's also an opportunity to drive value. I mentioned during my talk, for example, thinking about basic science investments. The current administration has a priority of focusing on disparities. Well, one way to kind of drive more value in the system is to create the technical opportunities for industry to help eliminate those disparities through new therapies targeted in those areas. There's opportunities around patent reform, opportunities around biosimilar reform. There are a lot of other ways to drive value through the system rather than just focusing on driving down prices.
Yeah, and so unfortunately with that, I think we need to start to close up here. We've got some great comments on the chat about the aspects of the German system, and the one that caught my eye is that Germany is effectively a system of nonprofit plans who are subsidized by the government and overseen by legislative committees at the state and federal level. Sounds a lot like where some people want to take us. And just, I guess I would, we had an important question about value-based payment arrangements from Tanaya Conti, and I'd love to follow back up with you afterwards. But I want to kind of leave us with this, and that is, I think, we know, HR 3 is kind of the thing on the table right now, and it requires, manufacturers to negotiate prices with HHS. And when we were designing the law, I worked directly on the non-interference clause, and people assume that because it says HHS it can't interfere in the negotiations between plans and drug manufacturers. They assume that there is no negotiation, and that's just not true, right? The plans and the drug manufacturers negotiate aggressively with each other to drive down prices. That's why we see stable premiums in the Part D market for at least the past 10 years. But HR 3 would require manufacturers to quote unquote negotiate with the secretary. Not clear what that exactly means or how it would be operationalized. But what we do know is that prices couldn't exceed 120% of the average price in those other countries. And the trade-off, therefore, is that we have fewer products available. And as Sue, you indicated, fewer products in the innovative categories where we really need the Alzheimer's breakthroughs to lower healthcare costs in this country. And that's why it's such a radical concept, and I've described it that way several times to Wendell Primus and others, and they kind of take offense at that. So I went back and I dug up the CMS actuary's estimate of HR 3 back in 2019 when it was first considered and passed the House. And what they said about this model, quote, was the legislation would represent a dramatic and unprecedented shift in how the prescription drug market operates in the United States. And that's a fair assessment. I think what you've hopefully heard today is that all the folks here have different ideas about how to make prescription drugs more affordable, and we should start there before going to a radical approach like that and contained in HR 3. So I want to thank all the panelists today. I want to thank all the comments and the questions in the Q&A. We've recorded this, as I indicated, so that people can access it. It'll be on our website later today. And I just really want to thank all the panelists. They are experts and they're wonderful people for sharing their time with us. Really, really great comments today. And thank you very much for participating.
Thank you.